Hi there, me again. This time, last but not least, pulmonary function testing. Keywords, learning objectives. Pulmonary function tests can be divided into three basic types. Those which are effort dependent, which involve breathing with forced expiratory volumes and measuring volumes and flow, otherwise known as spirometry. Effort independent tests, which are not forced expiratory, which I've listed there. And then what's known as the gas diffusion tests, which I've also listed as well. So if we start off, and this is the meat in the sandwich, if you like. Apologies if you're a vegetarian or a vegan. The vegetable in the sandwich, there we go. This is spirometry, which measures dynamic lung volumes. Now, you will need to know about this. This is going to come up in exams, so listen up carefully. So what we're measuring here is volume against time, a volume time curve, a forced expiratory maneuver, all the way from total lung capacity to where you can't breathe out anymore, which is residual volume. And the indices we measure are firstly the amount of expiratory volume forced out in the first second, FEV1, measured in litres or mils. The forced vital capacity, which is the total amount of air you can breathe out, FVC. The forced expiratory ratio, FER, which is the ratio of the FEV1 to the FVC, expressed either as a decimal or a percent, so like 0.75 or 70%. And also, you don't really need to know about is the relaxed vital capacity. So instead of doing a forced maneuver, you do a relaxed maneuver all the way out to residual volume. But you don't really need to know about that. I'm just telling you for information only. So this is a picture showing spirometry of a normal curve where you breathe out most of your forced vital capacity in the first second. So you can see the ratio of the FEV1 to the forced vital capacity is greater than 0.75. In an asthmatic volume time curve, you can see the gradient is less, so it takes longer to reach the same forced vital capacity. Okay. So it has a longer forced expiratory time, but you eventually get to the same forced vital capacity. And if you've got more severe asthma, then I guess it would look something like that. If you've got COPD, then the slope gradient is even lower. And crucially, key learning point here is that you don't reach the normal predicted forced vital capacity. So that's a big difference between asthma and COPD. And that difference between the normal predicted vital capacity and the reduced vital capacity in COPD, that would represent the increase in residual volume due to gas trapping. So the reason you can't reach a normal predicted vital capacity is because you've got all that air trapped in. You can get the air in, but you can't get it out. So the other thing we can measure, and I'm just going to tell you this for information, you don't really need to know this for the purpose of exam, are the expiratory flow rates. So if we go back, and if you plot dV by dt, the tangent here, or the gradient, volume versus time at each point, and you plot that against the lung volume, so if you plot the gradient, volume divided by time, against volume, then volume divided by time is litres per second, which is the flow rate plotted against the expiratory volume in litres, starting at total lung capacity and ending up at residual volume. That's known as a flow volume curve. There's a reason I'm going to show you this. There are shapes of flow volume curve depending on whether you've got volume dependent airway closure, where you get closure of the airways as you go from total lung capacity to residual volume. That's why it's called volume dependent. And you see that in asthma, or you see it in COPD with a chronic bronchitis component. Or you get a picture of pressure dependent airway closure. So as soon as you increase the airway pressure on initial expiration, the whole thing collapses like a concertina if you've lost the alveolar wall support. Think of a tent with guy ropes, and if you snip the guy ropes and a gust of wind comes along, the whole thing collapses. It's the same thing with emphysema. So these are patterns. That's a normal triangle flow volume curve. So That's total lung capacity, that would be residual volume, and that's the flow rate, volume divided by time. So in a normal person, you reach your peak expiratory flow rate, the maximum or peak expiratory flow very quickly in the first second, and then the flow declines linearly until you can't breathe out anymore and you've reached residual volume. That's normal. If you've got severe asthma or you've got a chronic bronchitis component of COPD, you can see basically, you can see there's this bite that's been taken out of the curve. So your peak flow is reduced, but you can see the actual expiratory flow rates are also reduced as well. So you take that bite out there, that tells you the difference between a normal curve and a volume-dependent airway curve. And finally, in purple or pink, is the pressure-dependent closure. So the peak flow is reduced, and then the whole thing collapses like a concertina. So those are the main patterns. The reason I'm showing you this is to show you where the peak expiratory flow rate comes from. So that's the peak flow that you can breathe out in the first second, which is usually expressed in liters per minute. So that would be liters per second times 60. Now, we don't give patients a spirometer to use at home. We give them a simple linear peak flow meter, which is calibrated to measure the peak expiratory flow rate, which costs a few pounds and is prescribable. So that's where the peak flow rate comes from. Now you know. We can also measure forced expiratory flow rates at different percentages of forced vital capacity. So we can measure the forced expiratory flow, say between 25 and 75% of forced vital capacity, and take the average, and that's known as the forced expiratory flow 25-75, or we can measure the forced expiratory flow at 50%. Anyway, the reason that's relevant is that this area here between 25 and 75% of forced vital capacity is determined by closure of small airways. So it's quite a sensitive marker of small airways disease. The other thing I haven't told you about is, let's go back to the spirometry, is a restrictive impairment of lung volumes. So if you've got restrictive lung disease, like interstitial lung disease, which Dr. Gowdy will teach you about, what happens is you get a shrunken normal spirometry curve. So it'll look something like this. It'll go like that, and then like that. So the FEV1 is reduced, and the forced vital capacity is reduced, but they're reduced in proportion to each other. So it's like a sort of a concertinaed or shrunken normal volume time curve, okay? So the FEV1 is reduced, and the FVC is reduced, but they're reduced in proportion, unlike in airways disease, where they're reduced disproportionately. The FEV1 is reduced more than the FVC. All right, so that's a restrictive pattern curve. So here is a table which you should commit to memory. It will serve you well for exams. So this is a money slide. So if we compare obstructive and restrictive patterns on spirometry, then the peak flow is reduced in an obstructive pattern, but because there's no airflow obstruction, the peak flow is actually normal in a restrictive pattern. There's no obstruction to airflow. Key learning point there. The FEV1 is reduced in obstructive, but it's reduced disproportionately to the forced vital capacity. Whereas in a restrictive volume time curve, the FEV1 is reduced in proportion to the FVC. So they're both reduced, but the ratio of FEV1 to FVC is still at least 0.75 or 75%. In asthma, the FVC, the forced vital capacity, is normally preserved, and in COPD is normally reduced because you've got air trapping and an increased residual volume. But either way, even in asthma where the FVC is preserved, because the FEV1 is reduced, the ratio will be less than 75%, 0.75. So your FEV1 to FVC ratio will usually be less than 0.75 in asthma and COPD. And the more severe your asthma and COPD, the lower the ratio. The other thing to note is that if you give a beta agonist like salbutamol to look at reversibility of FEV1, and you do a pre and 15 minutes post, you'll get more than a 15% change in asthma and less than 15% change in COPD. They're less reversible because you've got that smooth muscle hypertrophy in COPD. You don't have in asthma. If you do that to someone with a restricted impairment, say due to interstitial lung disease, like if they've got idiopathic pulmonary fibrosis, there's no response because they've got no airflow obstruction. Commit that to memory. So next bits for information, really, you don't need to know about, just need to know they exist, but you won't be examined on it. We can do bronchial challenge testing to induce bronchoconstriction. The way we can do that is exercise, or we can give a chemical like methacholine, histamine, mannitol. And that's the way in the clinic that we assess airway hyper-responsiveness. So we'll come to that. Or you can use an allergen or a chemical, particularly allergen. There are two phases to the allergen response. There's an early phase drop when you inhale allergen, then it recovers. And then there's a late phase response, which is typical of the allergic type 2 process. All right, so this would be a typical bronchoprovocation challenge test with, say, methacholine, which stimulates muscarinic 3 receptors, histamine, which stimulates H1 receptors. Both of these are on airway smooth muscle, or you can get the same response with cold, dry air. So basically, you give increasing doses of the drug inhaled, say, through a dosimeter until you see a 20% fall in FEV1. It's that 20% threshold. And that's called the PD20, the provocative dose of, say, methacholine or histamine required to produce an FEV1. And if that dose is less than 8 milligrams per mil, it means that you've got significant airway hyperresponsiveness. Now, we don't do that in all asthmatics, probably in only about 5% of patients where we're wanting to establish a firm diagnosis. So it might be someone who's got symptoms, who's got normal spirometry, where we want to see if they've got twitchy airways. Exercise testing is useful, especially for athletes, see if they've got a component of exercise-induced asthma, like all the cyclists who don't have exercise-induced asthma, who are still taking beta agonists because they think it'll improve their performance, God knows why. So, for example, Bradley Wiggins and was using salbutamol, and Chris Froome for that matter as well. This is where we're looking for a fall in FEV1 or peak flow after exercise. Now, normally what happens in exercise is you release endogenous adrenaline. So adrenaline's a beta-2 agonist, so it dilates your airway. So initially in exercise, even if you've got asthma, you dilate your airway. It's what happens when you stop exercising after and the adrenaline falls, is you get a rebound fall in FEV1 or peak flow. So it's the fall in FEV1 after exercise, which is what we're measuring to determine exercise-induced bronchoconstriction or exercise-induced asthma. The other thing we can do in exercise testing is put a finger probe on to measure oxygen saturation and to look at the fall in oxygen saturation during exercise. So this is something we might do in interstitial lung disease to monitor treatment response, for example. And this is measuring the impairment of the alveolar arteriolar barrier. It's that common basement membrane between the alveoli and the arteriole, which I showed you in the first talk. So it's looking at that. So if you've got, say, inflammatory infiltrate or fibrosis in the alveolar arteriolar barrier, which impairs the transfer of oxygen, then you'll desaturate on exercise. The other thing we can do is, which we only tend to do with elite athletes, is a full cardiopulmonary exercise test. And we tend to do that to try and differentiate between cardiac or respiratory causes of breathlessness in patients, apart from doing it in athletes, to see how fit they are. So what we measure is we measure heart rate against oxygen uptake and ventilatory rate, and looking at these plots, we can assess whether breathlessness is coming from the heart or from the lungs. Done in a very small proportion of patients, maybe 1 or 2% of patients I see go on to have CPAP. Static lung volumes, you won't be examined on these. It's for information purposes only if you want to read up. So these are effort-independent tests. It's not a forced expiratory maneuver. They're measured using a marker gas, either helium or nitrogen. Tend to use nitrogen. This is known as the white nitrogen washout test, which measures something called functional residual capacity. And if you know the functional residual capacity, you can calculate the residual volume. And if you know the vital capacity and you add the residual volume, you can measure the total lung capacity. To be honest, don't tend to do these tests very much in clinic, probably less than 5% of patients. You can get an increase in total lung capacity if you're hyperinflated from gas trapping with emphysema, or reduction in total lung capacity if you've got restrictive lung disease. In COPD, what we tend to see is gas trapping. So as well as seeing an increase in the total lung capacity, you see an increase in the residual volume. And so the ratio of residual volume to total lung capacity increases proportionately the more increase in residual volume you've got. But again, that's pretty much small print. And the bottom line is measuring total lung capacity adds very little to measuring either forced vital capacity or relaxed vital capacity with a spirometer. And it's a hassle to do, so we don't really do it. And this is just a plot if you want to work out what's happening with functional residual capacity, how that's related to residual volume, and vital capacity, and how that's related to total lung capacity. Again, for information purposes, no need to learn. And this is just showing you what happens in terms of gas trapping between a normal person and COPD. So if you don't want to look at this, don't worry if you find it confusing. This you do need to know about. This is diffusing capacity or transfer factor, call it what you will, the two are interchangeable. And this measures the diffusion of carbon dioxide across the alveolar capillary or alveolar arteriolar barrier, sometimes known as single breath diffusion capacity or total lung carbon monoxide or diffusion lung capacity for carbon monoxide. So TLCO and DLCO are interchangeable, but it's actually measuring the total lung transfer for carbon monoxide, the diffusing capacity, and you can measure the total, or you can correct that for alveolar volume, which is called the KCO or corrected. The TLCO or the single breath diffusion is reduced if you've not got enough red blood cells carrying the carbon monoxide, if you've got no alveoli, if you've got disease in the alveolar arteriolar barrier, interstitial lung disease like idiopathic pulmonary fibrosis, if you've got fluid from left ventricular failure, pulmonary edema, if you've got obstruction to the blood vessels or the pulmonary arteries, pulmonary emboli, and apparently if you've got bronchiectasis, it can be reduced as well, so the textbooks say. And it's really used to monitor the response in interstitial lung disease if you've got inflammatory infiltrate in the alveolar arteriolar barrier and you are treating that with anti-inflammatory drugs. Apart from that, it's really not used very much. Airway resistance, again, I'm just telling you this for information purposes only. You can measure resistance using something known as a body box or a whole body plethysmograph, or more commonly nowadays, we use something called impulse oscillometry. Impulse oscillometry measures airway resistance during quiet tidal breathing. So it means you don't do a forced expiratory maneuver. So it's very physiological because it's done with normal breathing. And what you do is there's a loudspeaker which bounces sound waves through a tube. The patient breathes in and out into the tube with a pressure transducer at one end of the tube, and it measures the reflection of sound waves. So it's a bit like sort of, call it bronchial sonar, if you like, bouncing sound waves off the bronchial tubes. And depending on the frequencies of the reflected sound waves, and we tend to measure these at frequencies between 5 and 20 hertz, we can ascertain whether the resistance is coming from central or peripheral airways. So the resistance at 5 hertz, for example, is the total air resistance, and the resistance at a higher frequency at 20 hertz is the central air resistance in large airways. So if you subtract total 5 minus central 20, you can get the peripheral airway resistance, which is a useful thing to measure, more in asthma than in COPD. It's very useful in kids because it requires no cooperation. You're just breathing normally at quiet tidal breathing. So it's much easier than doing a forced expiratory maneuver. But again, you won't be examined on that, information only. Exhale, breath condensate, information only. Do you remember I told you that measuring the fractional amount of exhale breath nitric oxide is a marker of type 2 inflammation, and specifically that mediated by interleukin 13. So it's a very simple exhaled breath nitric oxide monitor, which can be done at point of care in the clinic. So it's the only way in the clinic with the patient at point of care that you can measure cytokine-mediated inflammation. So it is a really useful test, which I do in all of my patients. So all of my patients in the clinic get spirometry. All of my patients get impulse oscillometry to measure their peripheral area resistance, and they all get fractional exhaled breath nitric oxide. It's not useful in COPD because nitric oxide is suppressed by smoking. High levels of nitric oxide reflect uncontrolled asthmatic type 2 inflammation, and it's often used as an adjunct to bronchial challenge testing to assess whether patients have got asthmatic inflammation. Have they got asthma, yes or no? And if it's equivocal, you do a bronchial challenge test with an exhaled breath nitric oxide, particularly in patients who've got normal spirometry. So what happens is that if you've got twitchy airways, that will usually be accompanied by a raised level of exhaled breath nitric oxide. Now, I'm not going to be doing challenge testing routinely in the clinic. It takes too long, but a pheno test takes like 2 or 3 minutes. Spirometry takes about 5 minutes, impulse oscillometry, a couple of minutes. So here's another money slide. Now putting everything together, you need to commit this to memory. You will be asked on this. So obstructive against restrictive. Peak flow, reduced and obstructive, normal and restricted. FEV1, reduced in both. FVC, normal in asthma, reduced in COPD, reduced in restrictive. The ratio of FEV1 to FVC is reduced, so the FEV1 is reduced disproportionately in obstructive, but the FEV1 is reduced in proportion to the reduction in FVC in restrictive disease. So the ratio is greater than 0.75 and an obstructive less than 0.75. The gas transfer, or TLCO, is normal in asthma. You haven't got a problem with the alveoli, but if you've got no alveoli and you've lost them, then it's reduced in emphysema, and it's reduced in restrictive lung disease if you've got impairment in the alveolar arteriolar barrier, if you've got an interstitial lung infiltrate in the alveolar walls, or you've got fibrosis. The response of FEV1 to beta agonist is more than 15% in asthma, less than 15% in COPD, and in a restrictive pattern, there's no response at all. And that's it. Right, well, that's the end of my lectures. Have another great day. Take care and be safe.